All right, guys, renal stones. One of those topics that shows up everywhere on Step 2 and Step 3. We're going to cover everything today, and I mean everything: pathophysiology, diagnosis, management, prevention. Let's break it down properly. So imagine a patient walks into the ER at 2 a.m., grabbing their side, writhing in pain. That colicky flank pain, the kind that comes in waves and just doesn't let up. That's your classic stone presentation. The pain travels down towards the groin as the stone moves through the ureter. They're also nauseated, maybe vomiting, and there's blood in their urine. Now here's the thing the USMLE loves to throw at you. A child comes in with just blood in their urine, no pain whatsoever. You'd never think stone, right? But that's exactly what it is. Children with renal stones can present with painless hematuria only. Burn that into your memory. Okay, so let's talk about the actual stones. Think of it this way. 8 out of every 10 stones you'll ever see are calcium stones. That's how common they are. Now, within calcium stones, there are two types. Calcium oxalate, the more common one. These guys like acidic urine, low pH. If your patient has Crohn's disease, or they've been chugging vitamin C supplements, or God forbid drinking antifreeze, ethylene glycol, they're at risk. Under the microscope, they look like little envelopes or dumbbells. Treatment is pretty straightforward. Thiazide diuretics, citrate supplements, and cut the sodium. Calcium phosphate is the other type. Opposite situation, it likes alkaline urine, high pH. Looks like a wedge-shaped prism. Same treatment though. Thiazides and low-sodium diet. Now uric acid stones, only 5% of stones, but I promise you they punch way above their weight on the exam. Here's why. They are completely radiolucent, completely invisible on plain X-ray. So if your attending says get an X-ray, you're going to miss it entirely. Always go with CT or ultrasound for these. Think about who gets uric acid stones. Gout patients, people eating too much protein, Lesch-Nyhan syndrome, tumor lysis syndrome. Basically anyone with high cell turnover dumping uric acid into their urine. Treatment: alkalinize the urine and give allopurinol. Struvite stones are fascinating because they're essentially caused by bacteria. Urease-positive bugs, Proteus, Staph saprophyticus, Klebsiella. These organisms break urea down into ammonia, which makes the urine alkaline, and boom, stone forms. They grow huge. We're talking staghorn calculi that can fill the entire renal pelvis. Shaped like a coffin lid, also called sarcophagus shape. You can't just treat the stone. You have to kill the infection first, then surgically remove it. Cystine stones. These are genetic. Autosomal recessive. The PCT transporter in the kidney that normally reabsorbs cystine just stops working. And it's not just cystine. Remember COLA, cystine, ornithine, lysine, arginine. All of them fail to reabsorb. Cystine is poorly soluble, so it just crystallizes out. These start in childhood, can also form staghorn calculi, hexagonal-shaped. Remember, 16 has 6 sides, and the sodium cyanide nitroprusside test will be positive. Treatment: low sodium, alkalinize the urine, chelating agents if nothing else works. Alright, so your patient is in agony in the ER. What do you actually do? First thing, get them comfortable. Morphine or ketorolac for pain, antiemetics for the nausea, IV fluids. Now, while you're doing that, you need to be asking yourself 4 critical questions. Is there an infection? Is the kidney being damaged? Is the ureter completely blocked, meaning no urine is coming out at all? And is this pain just completely uncontrollable? If the answer to any of those is yes, this patient is not going home. Admit them, call urology urgently, push IV medications, and if the stone is between 5 and 10 millimeters, give an alpha blocker to help it pass. Strain the urine so you can catch the stone and analyze it. If everything is manageable, send them home with oral pain medications, hydration, same alpha blocker if the stone is 5 to 10 millimeters, and arrange outpatient urology follow-up. But if that stone is over 10 millimeters, or it hasn't passed in 4 to 6 weeks, or pain keeps coming back, urology needs to see them. Diagnosis: adults. Non-contrast CT abdomen and pelvis. That's your gold standard. Now, the USMLE will try to trick you here in two ways. First, they'll offer CT with contrast. Don't take it. Contrast can cause kidney injury and allergic reactions. Non-contrast is always preferred for stones. Second trick, urinalysis. Yes, hematuria suggests a stone, but it's non-specific. Tons of other things cause hematuria. Don't let that be your only diagnostic tool. Pregnant women are a special case. You can't just blast them with CT radiation. Start with regular ultrasound. Negative? Try transvaginal ultrasound. Still nothing? Either MR urogram, or if she's in her second or third trimester, low-dose CT is acceptable. Here's a clinical scenario I love. Patient comes in with this weird pattern of sometimes barely urinating and then suddenly urinating a huge amount. Intermittent obstruction from a stone. The stone partially blocks flow, urine backs up, pressure builds, then finally the urine overcomes the obstruction and rushes out. That's post-obstructive diuresis. And when that happens, they dump potassium and get dehydrated, causing weakness. Beautiful USMLE question. Myth buster time. And this is something even doctors get wrong. Do not tell your renal stone patient to reduce calcium. Counterintuitive but true. Low calcium diet actually increases oxalate absorption in the gut, making things worse. What you actually reduce is sodium. Keep calcium at 1,200 milligrams per day. For prevention, potassium citrate or bicarbonate for calcium stones, allopurinol for uric acid stones. And your mnemonic. AC high, you cry when low. Ammonium and calcium phosphate love high alkaline pH. Uric acid and cystine cry in low acidic pH. One line, 4 stone types sorted. Done. And if you ignore all of this and the stone just sits there, complications follow. Hydronephrosis as urine backs up, pyelonephritis as infection sets in, and eventually acute kidney injury. Don't let it get there. That's renal stones. First Aid, UWorld, and Amboss. All in one place. I scored 262 and 239 on my steps, and everything I make is built around what actually matters for your exam. Drop a comment telling me what topic you want next. I read every single one. Follow one